Hi, this is Dr. ROJoson, Director of ROJoson PEP TALK. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. I launched this PEP Talk on May 15, 2021 with a module on COVID-19. The second module was on patient empowerment. I am on my third module, patient management process. This module has 6 parts: overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patient process, and peculiarities and limitations of medical practice. What I have in mind in my PEP Talk, which may run for 3 years, is to empower at least 30 persons with my family members and my patients as a priority. That is my key performance indicator. I hope you will be in my group of 30. My PEP Talk today is entitled Patient Management Process and Overview. I will give you 1 second to have a quick glance at the framework of the patient management process so as to prime you on my talk, but I will not discuss it yet as I want first to do a little introduction and give a backgrounder to the framework. The patient in the medical context is someone who has a health concern. That health concern has to go through the processes of problem solving and decision making to know what it is first, or diagnosis, and then to know what to do to resolve it, or treatment. This, in essence, is the gist of patient management process. As early as 1989, I formally formulated a patient management process framework or algorithm, which I have been using since then in my private practice and teaching in healthcare institutions such as medical schools and hospitals. Modesty aside, I find my PNP simple and practical to follow and to teach both the healthcare professionals and the lay people. Although this framework was originally made with the healthcare professionals, namely physicians and medical students, in mind, I honestly think it can be used to teach and should be taught to lay people so that there will be alignment of expectations from both parties, meaning the physicians and patients. In understanding the patient management process, lay people will know how to participate in the problem solving and decision making of their health concerns with their physicians. First and foremost, they will know what to ask the healthcare professionals before they make decisions on their health concerns. Second, they can evaluate whether the healthcare professionals are using proper and rational processes or not, such as using the matching type questions and answers in the recommendations. This could serve as a ground to seek opinion from another healthcare professionals, the so-called second opinion. In understanding the patient management process, even in the absence of healthcare professionals, lay people may know what to do with their health problems, at least the processes in problem solving and decision making. With this competence, they can gain greater control on what to do with their health concerns and issues. Now, do all the above benefits of knowing patient management process remind you of the concept of patient empowerment? pagpapalakas ng pasyente and the K4, kaalaman, kakayanan, karapatan, and kapangyarihan. The word about using processes versus using matching type questions and answers in problem solving and decision making. In matching type questions and answers in problem solving, you have premises and then straightforward responses. For example, if you have this symptom or set of symptoms and signs, then the diagnosis is this or that. If you need a paraclinical diagnostic procedure for a particular diagnosis, then the procedure should be this or that. Likewise, in treatment, it will be this or that for a particular type of diagnosis. The problem-solving and decision-making processes for health concern are more complex than performing matching type questions and answers, as we shall see later on. By the way, and suffice for me to say at this point, at this moment, a process is defined as a series of actions which are carried out in order to achieve a particular result. Here again is a diagram of my patient management process framework or algorithm. For today, I will just present the gist in each step and the involved processes. I will do the detailed discussion in the next sessions. The patient consults a physician. The goal of the physician is resolution of the health problem in such a way that the patient does not end up dead, as much as possible with no complications and no disability, in such a manner that the patient is satisfied. These are the universal goals of all physicians. And these are also rightfully the expectations of the patients. The patient consults a physician. What are the 4 basic categories of functions or tasks expected of a physician? These are rapport, diagnosis, followed by advice, treatment, followed by advice, and then advice. The general quality standards that can be used for these 4 tasks are rational, effective, efficient, and humane. After establishing rapport with the patient, the physician starts accomplishing the task of diagnosis. The physician does interview to get symptom data and does physical examination to get sign data, after which he does the clinical diagnostic processes to come out with a clinical diagnosis. The clinical diagnostic processes consist of pattern recognition and prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of disease. Prevalence process means choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and system. Clinical diagnostic process illustration 1. Knowing the common manifestations of 5 different diseases as follows. Disease A, ABCD manifestations. Disease B, FGHI manifestations. Disease C, KLMN manifestations. Disease D, PQRS manifestations. And disease E, UVWX. Given the patient manifesting with PQRS, your diagnosis is disease D. What is the process used? Pattern recognition. Another illustration, knowing the common manifestations of 3 different diseases and relative frequency of each as follows. Disease A with ABCD manifestation, but the least common. Disease B, the same disease manifestation, ABCD. Disease C, the same ABCD, but the most common. So given the patient manifesting with ABCD, your diagnosis is disease C. And what is or are the processes used? Mainly pattern recognition because of ABCD, but mainly prevalence. Presenting with these pictures with mouth defects, which has a cleft palate for a diagnosis, and which has a cleft lip and palate. And what is the processes or the process used? The one on the left side of the screen has cleft lip because only the lip is involved. The one on the right side has cleft lip and palate because the palate is also affected. The process used is pattern recognition. This patient has bulging eyes and enlarged thyroid. What is the diagnosis and what process is used? Bulging eyes and enlarged thyroid are the usual presenting signs of hyperthyroidism. We recognize a pattern for hyperthyroidism. Thus, the diagnosis is hyperthyroidism, and the process used is pattern recognition. Patient has cough, colds, fever, and tiredness. COVID-19, flu, and common colds present with the same set of symptoms. How does one process for a diagnosis? COVID-19 should be the primary diagnosis during time of COVID-19 pandemic. The process used is prevalence. During time of flu pandemic, epidemic, or outbreak, when COVID-19 and common colds are not common, flu should be the primary diagnosis. The process used is prevalence. The outputs of the clinical diagnostic processes are the primary clinical diagnosis, which is the most probable or most likely, and the secondary clinical diagnosis, the alternate or the second most probable or less likely diagnosis. After the diagnostic processes and formulation of the clinical diagnosis, the physician gives advice to the patient, meaning he tells and explains the findings and diagnosis and entertains and answers questions from the patient. After the formulation of the clinical diagnosis, the physician decides whether he needs a paraclinical diagnostic procedure or not. Paraclinical here means done after the clinical diagnosis. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you're not certain on the primary clinical diagnosis and you need to be certain or be more certain before treatment, then go for a paraclinical diagnostic procedure. To decide on the indication of the paraclinical diagnostic procedure, the physician uses 2 processes: degree of certainty on the primary clinical diagnosis and comparison of treatment plans for the primary and secondary clinical diagnosis. Illustration 1. If one is not certain of the primary diagnosis, say 60%, as a rule, one needs a paraclinical diagnostic procedure. If one is quite certain, say 90 to 99%, as a rule, one does not need a paraclinical diagnostic procedure. If the treatment plan for the primary and the secondary diagnosis are the same, one may not need a paraclinical diagnostic procedure. Illustration 2. High certainty, 98% for the primary clinical diagnosis. As a rule, no need for paraclinical diagnosis or diagnostic procedure, even though the treatment of the primary and the secondary diagnosis are different. After analyzing the indication for a paraclinical diagnostic procedure, the physician advises the patient on this by explaining the processes that he uses and the outcome of his analysis. He recommends, weights, and answers queries from the patient, allows the patient to decide, and forges a shared agreement. If there is a need for a paraclinical diagnostic procedure, the physician uses the BRCA processes. B stands for benefit, R for risk, C for cost, and A for availability. The physician gives or lists the various options of the paraclinical diagnostic procedures and then gives data on the BRCA. With the data given, the patient is asked what he prefers. Illustration. Accuracy of 99% for option 1, 90% for option 2, 60% for option 3. Cost, option 3 or option 1, the most expensive at 4,000. Which one will be chosen? Option 1, if patient can afford. If not, option 2 can be chosen because it has a 90% accuracy, which is high enough. So the advice given by the physician at this point consists of explaining the processes of selection, the BRCA, to choose the most cost-effective paraclinical diagnostic procedure, and to the desire of the patient. He can recommend. He weights and answers queries from the patient, allows the patient to decide, and forges a shared agreement. Assuming that a paraclinical diagnostic procedure is done, the physician has to interpret the results of the paraclinical diagnostic procedure. To do this, he uses two processes: assessment of the accuracy of the report and then correlation with the clinical findings. Then he advises the patient on his interpretation and proceeds to discussion of treatment. Before the selection of treatment procedure, the physician decides on the pre-treatment diagnosis, which is obtained from repeated assessment of the accuracy of the clinical diagnosis and paraclinical diagnosis and correlation of the two. He advises the patient on the pre-treatment diagnosis. He then spells out the objectives or aims of the treatment. He then gives or lists the various options of treatment, uses the BRCA processes in the selection, and gives data on the BRCA. With this data, or with the data given, the patient is asked what he prefers. Illustration. Greatest survival rate for option 1, least for option 3, cost greatest for option 2 at 6,000, which should be chosen? Option 1. So the advice given by the physician at this point consists of explaining the processes of selection, BRCA, to choose the most cost-effective treatment procedure, and to the desire of the patient. He can recommend, he weights and answers queries from the patient, allows the patient to decide and forges a shared agreement. Once a shared agreement is arrived at, the treatment is executed. Just before, during, and right after treatment, the physician advises patient on preparation, outcome, things to monitor, etc. After treatment, the patient advises the patient on health maintenance and disease prevention. With this step, one whole cycle of patient management, inclusive of the involved processes, is completed by the physician with full participation from the patient. That, in brief, is an overview of the ROJoson Patient Management Process Framework or algorithm. There's still a lot of nitty-gritty things to discuss or things to expound, but this will be done in subsequent sessions. Takeaway in this pep talk that are related to patient empowerment. Foremost, the ROJoson Patient Management Process Framework or algorithm clearly spells out the universal goals of treatment, the 4 basic categories of functions to be performed by the physician: rapport, diagnosis, treatment, and advice, and the involved processes that have to be done within each function. The problem-solving and decision-making processes for all health concerns do not simply utilize performing matching-type questions and answers. They are more complex. They involve a series of actions which are carried out in order to achieve a particular objective or result. In understanding the patient management process being done by the physicians, lay people will know how to participate in the problem-solving and decision-making of their health concerns with their physicians. With problem-based and self-directed learning, in the absence of healthcare professionals, they may even know what to do with their health problems within their capacity and capability. Understanding the patient management process will redound to patient empowerment. Pagpapalakas ng pasyente with its K4, kaalaman, kakayanan, karapatan, and kapangyarihan. This ends my pep talk for today. Thank you for your attention. Mabuhay kayong lahat.